Welcome back to Rad On Smart Review RadBio Edition. Today, we're diving into a really key topic. We're moving past the immediate radiation effects and looking at a critical long-term consequence, radiation carcinogenesis, and the models we use, to understand the risk.
Right. We spend so much time focusing on how radiation kills cancer cells and how it affects normal tissues right away. The acute stuff like skin redness, mucositis.
Yeah, the things patients see immediately.
Exactly. But this is about a major late effect, the potential for radiation to actually induce cancer itself. Let's just be clear up front. Radiation is a known carcinogen. It causes cancer.
A carcinogen.
Yeah, carcinogen.
And for you as residents, really, at any stage, this is absolutely fundamental knowledge. It touches everything.
How so?
Well, think about it, patient counseling, especially for long-term survivors like our pediatric patients. And then there's the whole foundation of radiation protection, how we design treatments, set safety standards.
Okay, so it's pretty central. What are we covering specifically then? We'll walk through how we classify this risk as a stochastic effect. We'll look at the dose-response curves, which are crucial for understanding how risk changes with dose. Big difference between leukemia and solid tumors there.
Okay.
Then latency periods, the waiting game. Factors that influence risk, like age, which is huge. The key models, especially the linear no-threshold model, or LNT, and DDREF, DDREF.
DDREF, got it.
And wrap up with the clinical side, secondary malignancy risk after radiotherapy, SMNs.
All right, sounds like a comprehensive plan.
Yeah.
Let's unpack this. Where do we start? How do we classify radiation causing cancer?
Okay, so the formal classification is that cancer induction is a stochastic effect.
Stochastic. Stochastic. What does that mean in, well, plain English?
Stochastic basically means random, probabilistic. It's all about chance. And for radiation carcinogenesis, this classification has a few key characteristics you really need to grasp.
Okay, weigh them out for us.
First, and this is, well, probably the most discussed and critical point, the idea of no threshold dose.
No threshold.
Right. The models we use for protection assume that, theoretically, any dose of radiation, no matter how tiny, carries some probability, some chance of kicking off the cellular changes that could eventually lead to cancer.
So it's not like, say, deterministic effects, where you need a certain amount of radiation before you definitely see something, like skin getting red.
Exactly.
Yeah.
That's the key difference. Deterministic effects like hair loss, skin burns, fibrosis, they do have a clear threshold dose. Below that dose, generally no effect.
Okay.
But with stochastic effects like cancer or those heritable genetic changes we'll talk about later, the model assumes there's no absolutely safe dose, no threshold.
Okay, no threshold.
Yeah.
What else defines stochastic?
Second, even though there's no assumed safe dose, the chance of the effect happening definitely increases as the radiation dose goes up. More dose equals a higher chance.
Probability goes up with dose. Makes sense.
And the third key point is that the severity of the effect, if it happens, is independent of the dose.
What do you mean?
Like if someone unfortunately gets a radiation-induced cancer from a relatively low dose exposure, that cancer isn't somehow less bad or less aggressive than one caused by a higher dose. The severity is the same. The chance of getting it was just lower at the lower dose.
Ah, okay. So it's kind of an all or nothing thing at the cell level. Either the critical hit happens and starts the cancer process, or it doesn't. The dose just changes the odds of that hit happening.
That's a great way to put it. It's about the odds of that initial trigger. And that's fundamentally different from deterministic effects, where the severity, how bad the skin reaction is, how much function is lost, is directly related to the dose you got above that threshold.
Got it. Stochastic. Random, no threshold assumed for protection, probability up with dose, severity independent of dose.
Determinist.
Threshold exists, severity up with dose. That distinction feels very testable.
Oh, absolutely. High yield for your boards. Definitely know that difference.
Okay, so we know it's about probability, but how does that probability actually change with dose? You mentioned it's not the same for all cancers. Let's talk dose-response relationships.
Right, and this is where the data comes in, mostly from studying human populations. The absolute gold standard, the data set that informs almost everything we know here, is the lifespan study, the LSS, of the atomic bomb survivors from Hiroshima and Nagasaki.
Right, the A-bomb survivors. Decades of follow-up.
Decades. And these studies clearly show that different cancer types have different relationships with radiation dose. They don't all follow the same curve.
Okay, let's start with leukemia. That's often the first one people think of with radiation, right?
It is. And for radiation-induced leukemia, generally speaking, and this is an important point, We exclude chronic lymphocytic leukemia, CLL, which isn't really linked to radiation.
Okay, so excluding CLL.
Right. For the others, the dose-response relationship is best described by a linear quadratic no-threshold model, LQNT.
Linear quadratic. Okay, so the risk goes up with the dose that's the linear part, but also with the dose squared, the quadratic part.
Precisely. So if you imagine plotting this risk on the vertical axis, dose on the horizontal, the linear bit means it starts going up, but the quadratic part means it curves upwards, getting steeper as the dose gets higher. The risk increases faster than just proportionally.
But wait, there's something specific about leukemia at very high doses, isn't there? Something that seems counterintuitive at first.
Yes, this is absolutely key and often tested. At very high doses, we're talking several gray, maybe more, the observed risk of leukemia in the A-bomb survivors actually decreases. The curve turns down.
Risk goes down at high doses. Why would that happen?
The leading explanation is cell killing. At those really high doses, yes, you're causing damage that could lead to cancer, but you're also just killing a huge number of cells outright, including the very cells that might have been damaged in a way that could lead to leukemia. You're basically eliminating the cells that were at risk.
Yeah. It's like you don't just damage the blueprints in the factory, you actually burn the whole factory down.
Right.
So it can't produce anything faulty or otherwise.
That's a pretty good analogy, yeah. You wipe out the potential source. Now, solid tumors, they behave differently.
Okay, solid tumors. Things like lung cancer, breast, thyroid, stomach, colon.
Yeah.
The big ones. What's their dose response look like?
For solid tumors, based mainly on that same A-bomb data and other studies, the relationship is generally best fit by the linear no-threshold model, LNT.
LNT. So on that same risk versus dose graph, that's just a straight line. Starting at 0 and going straight up.
That's the model, yes. It assumes the excess cancer risk is directly proportional to the radiation dose, right from the get-go, from 0 dose.
And no downturn at high doses like with leukemia?
Generally, no. We don't see that downturn for solid tumors in the A-bomb data, at least not up to the doses where we have reliable information, which is around 2 to 3 sieverts. Remember, sievert is the unit for dose equivalent, factoring in a radiation type for protection purposes.
Sievert, right. So picturing the graphs, leukemia's LQNT curves up, then drops at high dose. Solid tumors are LNT, straight line up from 0.
You got it. Different cells, different sensitivities to damage versus killing. And for radiation protection, especially thinking about solid tumor risk over a lifetime from lower doses, that simple linear LNT model is what's widely used. It's seen as conservative, meaning it likely won't underestimate the risk.
Okay, dose matters. The shape of the curve depends on the cancer. What about timing? This leads us to latency, the waiting game. These cancers don't just appear the next day, right?
Not at all. There's a significant delay, the latency period, between getting the radiation exposure and when the cancer actually shows up clinically. And again, it's a big difference between leukemia and solid tumors.
Okay, how long is the wait for leukemia?
Relatively short compared to solids. You typically start seeing excess leukemia cases appearing about 2 to 5 years after the exposure.
2 to 5 years.
The risk then peaks pretty quickly, usually around 5 to 7 years after exposure. After that peak, the risk does start to decline, but it can stay elevated above the normal background rate for a long time, maybe 20, 25 years, sometimes even longer.
So quick rise, peaks early, then a long tail. What about solid tumor latency?
Much, much longer. You almost never see excess solid tumors in the first 10 years.
10 years minimum.
Yeah, minimum. They generally don't start appearing until at least a decade has passed, and often it's more like 20, 30, even up to 60 years after the initial exposure.
Wow, 60 years. Decades later.
It is. And critically, unlike leukemia, where the risk eventually comes down, the risk for radiation-induced solid tumors seems to persist for the rest of a person's life.
So if you were exposed as a child, that increased risk basically stays with you forever.
That's what the evidence suggests. It appears to be a lifelong increased risk, which really underscores why those long-term follow-up studies, like the A-bomb survivors or childhood cancer survivor cohorts, are so vital. You have to track people for their entire lives to capture the full picture, especially for solid tumors.
And it highlights why treating young patients is such a responsibility. They have the longest time ahead of them for these late effects to potentially manifest if they're cured of their first cancer.
Precisely. Their long latency means they are the group most likely to actually experience these late effects.
Okay, so we have dose, the dose response shape, the latency period. What are the other major factors influencing radiation cancer risk? What else modifies that chance?
Dose is obviously the main driver, but yeah, several other factors can significantly change the risk for a given dose.
You mentioned dose rate earlier being linked to repair time.
Yes, dose rate is important. Radiation that's delivered slowly over a long time low dose rate or broken up into many small fractions, like in standard radiotherapy.
Right.
That's generally less effective at causing cancer per gray than the same total dose delivered all at once, very quickly, high dose rate, or acute exposure.
And that's because the cells have more time to fix the damage between hits.
Exactly. More opportunity for DNA repair mechanisms to kick in and fix sublethal damage before it accumulates or gets misrepaired into something potentially cancerous. This is where that DDREF factor DDREF comes in. It's meant to account for this reduced effectiveness at low dose rates.
The DDRE, okay, we'll circle back to that specifically. What about the type of radiation? Linear energy transfer? LET. High LET versus low LET.
Yep, linear energy transfer. LET describes how densely the radiation deposits energy as it travels through tissue. High LET radiation, things like neutrons, alpha particles, dumps a lot of energy in a very short track, very dense.
Okay.
Low LET radiation, like the X-rays and gamma rays we typically use in therapy, or electrons spreads its energy out more sparsely along its track.
And how does that density affect cancer risk?
High LET radiation is generally much more biologically damaging, including for cancer induction per unit of absorbed dose per gray, compared to low LET radiation. We say it has a higher relative biological effectiveness, or RBE, for carcinogenesis.
Higher RBE means more carcinogenic per gray.
Correct. Neutrons, for instance, can have a pretty high RBE for causing cancer, especially at lower doses, because that dense track of damage is really hard for cells to repair correctly. It often causes complex clustered DNA breaks.
Okay, so higher LET, higher RBE, higher cancer risk per unit dose. Got it. Now, there's one factor I know gets absolutely hammered into us during training: age at exposure.
This one is huge GE, absolutely critical. It's probably the most important modifying factor after the dose itself. Children are significantly more sensitive to radiation-induced cancer than adults. It's not even close.
How much more sensitive? What kind of numbers are we talking?
The estimates vary a bit depending on the cancer type and study, but the lifetime risk for someone exposed as a child might be something like 10 to 15 times higher than for an adult who received the exact same dose.
10 to 15 times.
Wow. It's a massive difference. And it's the primary reason we are so careful with radiation doses in pediatric patients, both for diagnostic scans and, of course, in radiotherapy planning. We absolutely minimize dose wherever possible.
Which specific cancers are children most sensitive to?
The increased sensitivity is particularly noticeable for thyroid cancer, breast cancer, and leukemia.
That really puts the ALRA principle as low as reasonably achievable into perspective for kids, doesn't it? Okay, what about tissue type? Are some organs just inherently more prone to becoming cancerous after radiation?
Definitely. There's a wide range of sensitivities across different organs and tissues. For the boards, you definitely want to know the high sensitivity ones.
Give us the high sensitivity list. Who's most at risk?
Okay, high sensitivity tissues. Bone marrow is top because that's where leukemia arises. Then the thyroid, female breast tissue, the lung, and the stomach. Those are generally considered the most sensitive organs.
Okay, bone marrow, thyroid, breast, lung, stomach. What about moderately sensitive?
Moderate sensitivity would include organs like the colon, the bladder, the liver, esophagus, and the ovary.
And lower sensitivity tissues.
Lower sensitivity includes the bone surface, the skin, and the brain or central nervous system. Though, remember, even lower sensitivity doesn't mean zero risk, especially at higher therapeutic doses. It's just less likely compared to the high sensitivity group.
Are there any tissues where radiation really isn't considered a major cause of cancer, where the link is weak or non-existent?
Yeah, there are some. We sometimes call them relatively insensitive tissues based on current data. This includes the prostate, the pancreas, the larynx, and the uterine cervix. Of course, for cervix cancer, the overwhelming cause is HPV infection, not radiation.
That's an important point. Okay, last factor. Does sex matter? Male versus female?
Yes, it does seem to. For many solid cancers, females tend to have a higher radiation-induced risk than males given the same dose exposure. This is particularly clear for thyroid cancer and obviously for breast cancer. Overall, the total risk for developing any solid tumor after radiation exposure is generally estimated to be higher for females.
Okay, so let's recap the factors modifying risk. Number one is dose. Then age at exposure is critical children way more sensitive. Dose rate matters. Lower rate is less risky per gray, which leads to DDIAE. What matters high? LET like neutrons is worse, higher RBE. Tissue type matters. Bone marrow, thyroid, breast, lung, stomach are highly sensitive. And sex matters. Females generally higher risk for solid tumors. Phew, that's a lot to juggle.
It is. And understanding how these factors combine is key for risk assessment. It's not just about the dose number. It's about who got it, how they got it, fast or slow, what kind of radiation it was, and where in their body it went.
Which brings us right back to the models used for protection and estimation. The linear no-threshold model and DDRF. Let's focus on those now. The LNT model.
Right, the linear no-threshold model, LNT. As we said, this is the workhorse model adopted basically worldwide for radiation protection purposes, especially for estimating solid cancer risk from low doses.
And its core assumption again, any dose, no matter how small, carries a risk that's directly proportional to the dose. A straight line graph going up from zero.
Correct. That's the essence of LNT, and it's generally seen as a conservative assumption.
Conservative meaning it probably overestimates the risk at very low doses.
That's the thinking, yeah. It might overestimate the actual risk at very low doses and low dose rates because it perhaps doesn't fully account for the efficiency of DNA repair mechanisms when damage is minimal and there's plenty of time. But it's chosen for radiation protection because it's conservative. It provides an upper limit on risk, aiming to err on the side of safety when setting exposure limits for workers or the public.
Safety first. Makes sense. Now, where does DDREF, DDREF fit into this LNT framework?
Okay, DDREF, the dose and dose rate effectiveness factor. This is absolutely essential for applying LNT realistically in many situations. Remember, most of our best human data, especially for solid tumors from the A-bomb survivors, comes from very high doses delivered almost instantaneously acute, high dose rate exposures.
A single massive burst.
Exactly. But most occupational exposures, environmental exposures, even many medical exposures outside of a single radiotherapy fraction happen at a much lower dose rate or are spread out over time. So DDREF is used to bridge that gap.
How is it used? How do you apply it?
You take the risk estimates that were derived from the high dose rate studies, like the A-bomb data, and you divide them by the DDREF value. It acts as a reduction factor.
To lower the estimated risk for low dose rate scenarios.
Precisely. It's acknowledging that radiation delivered slowly is less damaging, less carcinogenic per unit dose than radiation delivered quickly. Again, likely due to better DNA repair.
And what value is typically used for DDREF?
The major international body, the ICRP International Commission on Radiological Protection, currently recommends using a DDREF value of 2.
2. So the ICRP basically says the cancer risk per gray at low dose rates is about half of what it is at high dose rates.
That's the practical implication, yes. A factor of 2 reduction when moving from high dose rate data to low dose rate risk estimation.
Has everyone just agreed on 2? Is that settled science?
Oh, definitely not. The precise value of DDREF is, let's say, an area of active scientific discussion and debate. Some researchers argue, based on various biological data or epidemiological reanalyses, that the evidence might support a value closer to 1, meaning little or no reduction for low dose rate. Others argue it could even be higher than 2.
So it's not set in stone.
Not entirely. Where you set that DDRA value has pretty significant implications for setting radiation protection standards and estimating risks for, say, airline crews exposed to cosmic rays, or people working in nuclear industries, or even for estimating risks from multiple CT scans over time. So it's a really important parameter that's still being refined.
That uncertainty really highlights the challenge of extrapolating, doesn't it? Taking data from one extreme scenario and applying it to another. Okay, let's shift gears and bring this firmly into the clinic. Let's talk about secondary malignancy risk following radiotherapy SMNs. This is something we have to discuss with our patients.
Absolutely. This is a critical clinical concern, especially now that our treatments are more effective and we have more long-term cancer survivors than ever before. Secondary radiation-induced malignancies, SMNs, are basically new cancers that develop years, sometimes decades, after a patient was successfully treated with radiation for their initial primary cancer.
And where do these SMNs tend to show up?
Most commonly, they arise within or very near the area that received a significant radiation dose during the original treatment. Sometimes in tissues just outside the main field that got scattered radiation. Less commonly, maybe at distant sites, but the risk is much lower there. The main risk is in or near the treated volume.
What's the ballpark risk? Is it high?
You know, the absolute risk for any given patient is generally low, especially when you compare it to the risk of their original cancer coming back. But it's definitely not zero, and it becomes a really significant consideration for patients who are cured and expect to live for many years. And as we keep stressing, it's particularly critical for pediatric patients because of their higher sensitivity and longer potential lifespan.
What kinds of cancers do we see as SMNs? Is it the same list?
Pretty much, yeah. It follows the patterns we've discussed. We see leukemias and then a whole range of solid tumors, sarcomas, carcinomas, depending on what tissues were irradiated. And the latency periods we talked about apply here too.
Shorter for leukemia, longer for solid tumors.
Exactly. Leukemias might appear within, say, 5–10 years after treatment. Solid tumors like sarcomas or carcinomas in the radiation field typically take much longer, 10, 20, 30 years or more to develop.
And the risk depends on.
All the factors we discussed. The dose received by the normal tissues in the field, the volume of normal tissue that got irradiated, the patient's age when they were treated younger age means higher risk later, and possibly their individual genetic makeup. Some people might just be more susceptible.
This brings up the issue of modern techniques like IMRT, intensity modulated radiation therapy. We use it to shape the dose so precisely to the tumor and spare nearby organs, right? How does that play into SMN risk?
Right. IMRT is fantastic technology. It allows us to deliver highly conformal high doses to the tumor while significantly reducing the high dose hitting adjacent critical structures like the spinal cord or salivary glands. This is a massive win for reducing acute side effects and early-late toxicities.
But there's a but, isn't there?
Well, there's a trade-off, or at least a theoretical consideration. To achieve that high conformality, IMRT often uses many small beams coming from lots of different angles. The consequence can be that while the high dose is tightly focused, a larger volume of surrounding normal tissue ends up receiving a low dose of radiation. This is sometimes called the low-dose bath or increased integral dose.
So less high dose to critical spots, but more tissue getting some dose even if it's low.
That's the potential issue. And if you strictly follow the linear no-threshold model, which says any dose carries risk, then irradiating a larger volume, even at low dose, could theoretically increase the total number of induced secondary cancers down the road compared to older techniques that might have hit a smaller volume overall, even if they weren't as good at sparing specific organs from high dose.
So a theoretical concern based on applying the LNT model to IMRT's low-dose bath.
Exactly. It's a theoretical risk based on LNT. And it's really important to stress that the proven clinical benefits of IMRT better tumor targeting reduced high-dose toxicity to critical organs, leading to better quality of life. These are substantial and usually outweigh this theoretical low-dose risk for most adult patients.
But it's still a consideration, especially for certain groups.
Yes, particularly in populations where we're most concerned about long-term effects, like children who are more sensitive and have longer to live. This theoretical concern about the low-dose bath is one of the major drivers behind the increasing interest in proton therapy.
Because protons stop more abruptly, the Bragg peak.
Precisely. Protons deposit most of their energy at the end of their track, the Bragg peak, and deliver very little dose beyond the target. This significantly reduces the integral dose, the total energy deposited in the body, including that low-dose bath. So the hope is that proton therapy could potentially lower the risk of SMNs compared to photon therapy like IMRT, especially in pediatric patients or maybe those needing re-irradiation. It's still an area of active study and clinical evaluation, comparing long-term outcomes.
So understanding SMNs isn't just academic theory. It's vital for our day-to-day practice, for informed consent conversations with patients about the potential long-term trade-offs of treatment. And it loops right back to ALARA.
Absolutely. ALARA, as low as reasonably achievable, has to be our mantra. We have a fundamental responsibility to minimize the dose to normal tissues as much as we possibly can, while still ensuring we give an effective curative dose to the tumor. This balance is especially critical when treating children. And remember, the dose limits we have for radiation workers and the public, those are based on these LNT risk models, incorporating factors like DDREF. It all connects.
Okay, this has been a lot of information. Let's try to pull out some high-yield clinical pearl stuff you absolutely need to have locked down for board review.
Good idea. Okay, pearl number 1. Radiation carcinogenesis is a stochastic effect. Remember the key features? No threshold assumed for protection. Probability increases with dose. But the severity, if it occurs, is independent of dose. Stochastic is about chance. Contrast that with deterministic effects, which do have a threshold and severity is dose-dependent.
Got it. Stochastic chance, no threshold. Pearl 2.
Pearl number 2. Know the dose-response shapes COL-D. Leukemia follows a linear quadratic no-threshold LQNT model. Key feature. It curves upwards but then turns down at very high doses because of cell killing. Solid tumors follow a linear no-threshold LNT model, a straight line up from zero, generally no downturn seen in the human data range. They love asking about that leukemia downturn.
LQNT for leukemia with downturn, LNT for solids. Okay. Pearl 3.
Pearl number 3. Age at exposure is huge E. Children are drastically more sensitive than adults. Remember that 10 to 15 times higher lifetime risk figure. This is critical for pediatrics, obviously, but also important when counseling young adults. Think especially thyroid, breast, and bone marrow leukemia sensitivity in kids.
Age is key. Pearl 4.
Pearl number 4. Just remember the list of key modifying factors. Dose itself, age at exposure, dose rate, lower rate equal less effective per gray, related to DDREF. Let like neutrons more effective, higher RBE, tissue type, no, the high sensitivity list, marrow, thyroid, breast, lung, stomach, and late sex. Females generally higher solid tumor risk. They can ask questions based on any of these.
Dose, age, rate, LET, tissue, sex. Got it. Pearl 5.
Pearl number 5. Understand LNT and DDREF. LNT is the conservative model used for radiation protection, assuming risk is proportional to dose from zero. DDREF is the factor, currently recommended as 2 by ICRP, used to reduce risk estimates derived from high dose rate data when applying them to low dose rate or fractionated scenarios because of repair.
LNT for protection, DDREF of 2, adjusts for low dose rate. Okay, last one, Pearl 6.
Pearl number 6. Secondary malignancies, SMNs, are a real known late effect of radiotherapy, especially important for long-term survivors in pediatric patients. They typically arise in or near the treatment field and follow those latency rules. Shorter for leukemia, years, much longer for solid tumors, decades. Modern techniques like IMRT have that theoretical low-dose bath concern based on LNT, but their clinical benefits are usually substantial. Proton therapy aims to reduce that integral dose.
Excellent, Pearls. Knowing those points really covers the core concepts.
Yeah, they not only help you on exams, but they genuinely make you a more informed radiation oncologist when you're talking with patients about risks and benefits.
All right, speaking of exams, let's do a quick board review blitz. Ready?
Let's do it. Hit me.
Question 1. The induction of cancer by ionizing radiation is best classified as what type of effect? A, deterministic with threshold, B, stochastic with threshold, C, deterministic with no threshold, or D, stochastic with no threshold.
Okay, that's testing the fundamental classification. Cancer induction is about probability, not certainty after a threshold, and for protection, we assume no threshold. So that's D, stochastic with no threshold.
Correct. D is the answer. Stochastic, no threshold. Question 2. Based on atomic bomb survivor data, the dose-response relationship for radiation-induced leukemia typically follows which model? A, linear no-threshold LNT, B, linear quadratic no-threshold LQNT, C, threshold linear, D, sigmoidal.
Leukemia. Okay, that's the one with the curve and the downturn. Linear describes the initial part, quadratic describes the upward curve, and it's no threshold. So that has to be B. Linear quadratic no threshold LQNT.
Correct again. B, LQNT for leukemia. Question 3. Which of the following generally has the shortest latency period following radiation exposure? A, radiation-induced thyroid cancer, B, radiation-induced lung cancer, C, radiation-induced leukemia, or D, radiation-induced skin cancer.
Shortest latency. Solids take decades. Leukemia peaks much faster, around 5-7 years. So the answer has to be C, radiation-induced leukemia.
C is correct. Leukemia has the shortest latency. Last one, question 4. The dose and dose rate effectiveness factor, or DDREF, is used in radiation risk assessment primarily to do what? A, account for the higher RBE of neutron radiation. B, adjust risks for different ages at exposure. C, extrapolate cancer risks from animal studies to humans. Or D, extrapolate cancer risks observed at high doses and high dose rates to low dose and low dose rate scenarios.
Okay, DDREF. That's all about adjusting for the rate of exposure. High dose rate data, like A-bombs, versus low dose rate, like occupational. So it's used to extrapolate between those scenarios. That's D.
Exactly right. Extrapolating from high dose rate data to low dose rate situations. Nail those 4 concepts, and you're in really good shape for the RadBio questions on carcinogenesis.
They are foundational. But remember, as we touched on, this isn't all perfectly settled science either. There are ongoing controversies and areas of study.
Like the exact value of DDR,
Yeah, that's a big one. Is it really 2? Should it be higher? Lower? That impacts risk estimates quite a bit. And then there's the ongoing evaluation of the real-world clinical significance of that low-dose bath from IMRT. We see the benefits of IMRT clearly in reducing high-dose toxicity, but quantifying the long-term SMN impact compared to older techniques or protons, that takes decades of follow-up.
Which is why research continues and why techniques like proton therapy are being actively investigated, especially for kids, to try and minimize that theoretical risk even further.
Exactly. Our understanding is always evolving, but those core principles we discussed, stochastic nature, the dose-response shapes, latency differences, the key risk factors, those remain the absolute bedrock.
Okay, so to quickly summarize our discussion on radiation carcinogenesis one last time, it's a stochastic effect. No threshold assumed for protection models. Probability goes up with dose, but severity doesn't.
Dose response curves differ. Remember LQNT for leukemia with the high dose downturn, and LNT for solid tumors.
Latency periods are key. Shorter for leukemia, peaking around 5-7 years. Much longer for solid tumors. 10+ years, risk persists for life.
Remember the big factors influencing risk. Dose is king, but age at exposure is critical. Children way more sensitive. Dose rate, lower is less effective, hence DDREF. LET, high is worse. Tissue type sensitivity varies, and sex plays a role.
The LNT model is used for radiation protection, assuming proportional risk. The DDREF factor, which the ICRP suggests is 2, is used to adjust risks from high dose rates down for low dose rates, accounting for repair.
And finally, secondary malignancies, SMNs, are a known, albeit generally low, late risk of radiotherapy, particularly important for long-term survivors and pediatric patients, underscoring why LRA is so fundamental to our practice.
You know, trying to remember all these risk factors, the LNT versus LQNT curves, the DDRF value after you finally pass the boards.
Yeah.
It's kind of like trying to find the proton therapy couch control after someone's hidden it as a joke.
Yeah.
Just disappears right when you think you need it most.
Props. Yeah, that's about right. A definite hazard of the trade. Well, speaking of long-term stochastic effects, we've talked about radiation causing cancer in the person exposed. Right. Next time, we'll tackle another major stochastic concern, the potential for heritable effects.
The risks to future generations.
Exactly. We'll delve into the genetic risks to offspring of irradiated individuals, looking at concepts like genetically significant dose and the doubling dose.
Sounds important. Okay. Remember, everyone, you can find practice oral boards and other great resources to help you master all this RadBio material over at radonsmartlearn.com. That's RADONCSMARTLEARN.com.
And definitely subscribe to Radiation Oncology Smart Review so you don't miss our next discussion on heritable effects.
Thanks so much for tuning in.
See you next time.